Hi, welcome. My name is Diana Berrent, and I am the founder of Survivor Corps. We are the world's largest grassroots COVID movement, and this is the latest in our webinar series, which has been going since April of 2020. And we have had the pleasure of interviewing some of the most brilliant minds in the world. And today is a perfect example. We know that you can't always get to the experts, so we are here to bring the experts to you. Today, we have two incredible guests who I think are both brilliant doctors and have become actual friends during this pandemic. So first we have Dr. Kavita Patel, who is a practicing physician of internal medicine at Mary Center. She is a non-resident fellow with the Brookings Institution. She also served in the Obama administration as director of policy for the Office of Intergovernmental Affairs and Public Engagement at the White House. You probably know her best from seeing her face most days on MSNBC and as an NBC News, MSNBC contributor on medical issues. Our next guest is Dr. Daniel Griffin. He is an instructor in clinical medicine and an associate research scientist in the Department of Biochemistry and Molecular Biophysics at Columbia University, as well as a senior fellow with United Health Corps with expertise in infectious disease. He is also one of the hosts and regular contributors to This Week in Parasitism. It's going to get worse in a second. A podcast about eukaryotic parasites.
You did well. Yes.
Okay. We were just going over my lack of medical training, even basic science training before we started. So this fits in perfectly. And infectious diseases clinical case studies. My favorite podcast that I listen to Dr. Griffin on weekly is This Week in Virology, known to the cool folks as TWIV.
Yes.
Look for it on your podcast. It comes out every Saturday morning, and it is the highlight of my week because it really does break things down, what the issues of the week have been, and to a point where you can really understand most of it. I can't say all, but it is at a high enough level that it challenges you to learn more, yet accessible to those of us like me who have not taken science since high school. So I'm going to start this with an opportunity for each of you to make some opening remarks based on three questions that I have, that if you could, in your opening remarks, sort of loosely address, the three, that would be great. And then we'll dig into questions that came from our members. And we had, as you can imagine, a lot of them, as just like at any point in this pandemic, there are far more questions than we have answers. And this is a great opportunity for us to listen to the two of you be able to speak in full thoughts and not in news bites. So please feel free. I'd rather get through fewer questions and hear more fulsome answers. So the three questions I'd love to hear you each address is, one, we are getting very mixed signals on Omicron and what it means. We know it transmits more easily, and yet it seems to lead to more mild infection. Some people say that's good news. Others say that this is the worst news possible. Can you explain that? Second question. So I guess that would be Epidemiology 101, again, that I didn't take. Number two, what do we know about long COVID and what have we learned since we've all last spoken in this forum? What's the latest? And third, very practically, I am getting calls left and right from friends who have been vaccinated, have been boosted, and are coming down with COVID. Very practically, what do you do if you get a positive diagnosis? Should you be seeking out monoclonal antibodies? We're hearing that monoclonal antibodies might not stand up to Omicron. What we hear about this magical pill from Pfizer or Merck that's coming out. Where is it? When's it coming? And will that work as an alternative, or should we be sticking with the monoclonal antibodies we have? I know I keep on bugging Dr. Griffin for updates on that from the $1 million mice or $150 million mice. Dr. Patel, can you go first?
Sure, I'm happy to, and I'll kind of take it maybe not all in the exact order. Well, I'll do the
No,
first
no,
question,
however you want, however you
kind
want.
of the Omicron. So here's what I'll say, and like all things in COVID, sometimes it feels like it's changing by the millisecond. And today kind of feels like one of those days, just because the World Health Organization put out what I would say is a pretty stern, dire, whatever adjective you want to choose, warning around kind of not taking to take Omicron seriously and to not just dismiss it because of like the reportedly mild cases. And so I think it put, I don't know, the two words that came up to my mind were like doomsday scenario, just because it put a lot of people, including friends around the globe, into kind of a tailspin of like, oh my gosh, what's happening. That combined with some CDC modeling, which quite frankly, like, and maybe Dr. Griffin, I'm hoping he'll disagree with some of what I say just to make it more interesting. But there was some CDC modeling that was also released yesterday, day before yesterday, recently, that illustrated that Omicron, yes, will kind of take hold, and that we will see an increase in cases that are pretty dramatic over the next couple of months. It's not anything kind of different than taking a back of the envelope. If you look and take something like a doubling time every 2 to 3 days and just do the math on like how much this virus can spread, because it's kind of the story we've been seeing for the last several years. That pains me to say that. But with this situation, I think what we're worried about is just the kind of literally the pace at which we're seeing new infections. By the way, not just with Omicron, but because of what happened over Thanksgiving, we're now seeing kind of the spillover effect and the results of a lot of people who were vaccinated, unvaccinated, kind of all comers who now are testing positive. And it's what's also leading to entire campuses closing. Just in my area, the DC, Maryland area, Howard County schools, DC public schools. I mean, a number of school districts are kind of going all virtual right before the holidays because there's so many cases of both isolation and quarantine. So it does feel there's this kind of palpable sense in the air clinically that like bad things are here, but more bad things are coming. And I think, but the only difference I would say is that I'm still trying to follow like cases globally, whether they're Omicron or Delta or whatever they are, cases globally, cases domestically, which are obviously not anywhere as low as I would like them. But I will say that hospitalizations have not proportionately kind of increased with the increase in cases. Or let me put it another way, a very kind of significant majority of cases that we're seeing, it doesn't mean that they're not important, but they're not leading to hospitalizations. And a lot of that does have to do with, even with breakthrough infections, we're seeing people who have been protected from hospitalization by the vaccines. So that actually is like a win in my book, but a big kind of column of losses if you're keeping score. And Omicron, how does that factor into that? I think that that's kind of to be determined. We know it's going to be bad in the sense that it's more transmissible. And I think I'm going to defer to Dr. Griffin on like why, well, I'll tell you that why I think that it's both good news and bad news when we say something like it's more transmissible but less virulent or less severe. The key part there is that it's more transmissible. So you don't want something that's so easy to infect others with, an airborne virus. It's the stuff out of science fiction, an airborne virus that's potentially more easy to spread than, measles, and causes in many people long COVID and other symptoms, not necessarily always leading to mild infections. So there have been a number of debates about why some of the data from South Africa demonstrates, or data emerging globally demonstrates, that people who have Omicron seem to be, people who were infected with Delta seem to be reinfected with Omicron. And some very smart people, not me, there was a nice Twitter thread by a friend, like someone I really respect, Trevor Bedford, who kind of had like a hypothesis and explanation for why that happens. All in all, though, I think that what we do know is that our current vaccines, including that third dose, if you had an mRNA shot, really do help us stay out of the hospital. Does not, I think Survivor Corps, I'm a big fan of Survivor Corps just because you don't leave people behind. So it's not just about the cases we are diagnosing and seeing today, but it's about people who had it in December of 2019, didn't even know they had it until things started to emerge around long COVID. And what worries me is that we've got a healthcare system. I mean, I saw it today. We have so many new cases coming up that now I've had to take people that have had long COVID or recently recovered from COVID, and they're just on the back burner. There's just like no energy or appetite or ability even to kind of deal with it in the here and now. And that's where I worry about, like, I'll talk about that as like our global situation. And then in terms of what we learned about long COVID, I mean, Diana and some others on this webinar were co-authors of a preprint publication that I would encourage folks to read. I'll tag it in Twitter when we're done, because I cannot tweet and talk at the same time. But I do think that just we do not have anywhere near enough information about long COVID that to my satisfaction. However, we're getting through efforts from Survivor Corps, real world kind of data that you all are many of you are providing. We're getting more and more information that I think has been helpful to identify some very kind of constellation of symptoms that are now allowing for us to be able to say, aha, we think this is what this might be: internal vibrations, tremors. There are, I can go through every kind of organ system or every physiologic and organ system and talk about symptoms that we're seeing with long COVID. So we do know more about that. And I do feel like that's progress, but it feels like a little bit of like, empty progress, because I don't have much I can offer. However, what's really exciting, doesn't get any news, are some of the kind of pipeline of treatments and therapies that are even in the molecular phase. And I think they're very exciting because they are trying to deal with some of the sequelae of COVID. We're not going to see that come to fruition, most likely with an FDA approval, for a while. And there's a reason behind that, because they need to be researched and studied. But I am optimistic that, unlike with other things in patients where I still have people with chronic pain syndromes and other diseases, that I have nothing to offer them except symptomatic relief. I'm hopeful that, given how massive long COVID and how large of a problem it is globally, that we'll get more information about it. Let's see, what else, Diana? If I had COVID right now, so I've got a lot of people that have COVID. I'm in the outpatient setting, so Dr. Griffin can also kind of talk about what he might be seeing on the inpatient setting. From an outpatient perspective, we're trying to get people monoclonals. We're dealing with Delta. We're still sequencing and seeing in kind of my region, Delta. Yes, we do have Omicron, but it's still Delta. So we're still kind of going back to the basics. We're doing monoclonals. I will tell you, though, we're having monoclonal kind of issues with supply, because, as you know, the distribution is kind of a little bit more allocated and controlled, not by me. And so it's not necessarily as plentiful as it used to be, or you have to kind of do a little bit more detective work to get to it. And then we're also being very vigilant, even though a lot of people that are positive are surrounded by people who are vaccinated. We're not taking that lightly. And I'm pretty much telling people, look, if you're positive, you treat it true isolation. And even if people around you are vaccinated, don't take that as a foregone conclusion that they're completely impenetrably shielded from having any infections or side effects. I think we've done a poor job. I'll take responsibility. I've done a poor job kind of messaging that the vaccine doesn't prevent you from getting infected. We sure as heck don't want you to, especially while we've got a health system that feels like it's collapsing under us. But it doesn't prevent you from getting infected. And that can come with some implications for, if you're positive, what to do, and if you know someone who's positive, what to do. Okay, so that was pretty long, Diana, so I'll stop there.
That was great. Before we go to Dr. Griffin, I just want to mention that if you are having trouble finding monoclonal antibodies, we have a website that we set up back in March called .covid.org. It lists all the ways to get monoclonal antibodies. If you are still running up into problems, email us at hq@survivorcorps.com. We have helped dozens of people just in the last 24 hours, and we've gotten free at-home infusions to them. And we are trying to bring that around the country. Unfortunately, the government hasn't, so we are stepping in to do that work because it is so important. Dr. Griffin.
All right. Well, that was fantastic. It's one of those, like, often you're waiting to speak, but I was listening and hoping Dr. Patel would just keep going because I learned a lot. No, I think I think that that's something over the last 2 years, which is a lot of humility. We learn a lot by listening to each other and shared experiences. But let me go through sort of the same issues. So I'll start with what's going on with Omicron. Here in New York, not so good. And the nice thing is the CDC keeps a variant tracking website. You can go to this, you can see where we are. Most of the country, it's all Delta. But if you look here in New York, we're in region 2, which is an odd region. It's New Jersey, it's New York, it's also Puerto Rico and the Virgin Islands. So I don't know what that's about. But we went from 0.4% Omicron to 13% for last week. And talking to my colleagues that are sequencing sort of outside of Wadsworth, we're probably going to be 30% when the numbers come in. So we are seeing a really rapid rise here in New York of the Omicron variant. So clearly this is a fit variant. Clearly this is a variant that can outcompete Delta. At least it is outcompeting Delta in this setting. And what's the bad? What's the good? I'm going to start with what the bad is. So the bad is it seems to be outcompeting Delta. So it is fitter than Delta. We don't know exactly what is that advantage? What allows it to outcompete Delta? Is it a shorter incubation period? That was huge with Delta. Instead of it being 7 days between exposure and the next cycle of transmission, we saw with Delta that dropped to only about 3.5, 4 days. So that was huge. We are seeing some early evidence that the changes in the spike protein may allow this virus, this variant, to bind to the ACE2 receptor better. There was some data I was looking at today where it may actually have a quicker viral replication cycle. So you may be getting quicker replication, higher levels in the upper airways. Not great from a potential transmission to the next person, contagiousness. The other, and I think this is really critical, is monoclonals. That's been a big focus of mine for a while. We got actually a couple preprints that I was looking at earlier today. It does look like this is breaking through our monoclonals. So which monoclonals? If you look at the spike protein and you look at some of the data that came out today, it looks like Regeneron cocktail is losing efficacy. As expected, it looks like the Eli Lilly is losing efficacy. What is really upsetting to me is it looks like the AstraZeneca pre-exposure prophylactic cocktail, it looks like that is also losing efficacy. It looks like the Vir GSK, which actually is a specific, we'll say, variant resistant monoclonal, that may be holding, but that's in really limited supply. So one of the tough things, right, is, we talk about management. Someone calls up, it's been a few days, I have COVID, I have a positive test, we don't know the sequence. Well, when 1 in 3 people that we send to get a Regeneron infusion are not getting a benefit from that's heartbreaking. That's huge, expense, that's huge effort, that's huge operational challenges. We get that person, we think we've done something. If this was their first infection, we're telling them not to get vaccinated for 3 months, and we may be giving them an ineffective therapy. So that is very difficult and troubling when I was looking through that information earlier today. And again, I hate to, we could have seen this coming, right? I think we've known for a while that this is a virus that can produce variants. The fact that Vir GSK was producing what was felt to be a more variant-resistant monoclonal, it would be nice if we had more of those. So that is impacting a little bit. But here's the other side, still focusing on Omicron. We are hearing early reports that people who are getting the Omicron variant infection are doing better. Well, so what's sort of the reality there? Well, a lot of those individuals being described in South Africa, this is a reinfection or an infection in someone who was previously vaccinated, or this is younger individuals. We expect them to do better. So that might be good. Because it could be the other. It could be that a reinfection, an infection of a vaccinated person results in serious disease. We are not seeing that, so that's encouraging. The other thing that I always point out is it takes time to die. So we initially see cases. We're seeing lots of cases, but it's going to take a couple weeks for people to get into that early inflammatory phase. And I always kind of go through the cycles. First week is a viral symptom phase. You feel crummy, but you're not in the hospital. That second week, you might end up in the hospital. We are seeing less hospitalizations. We're not sure if it's the variant or a background of younger, previously infected, vaccinated. But people tend not to die until the third or fourth week. So we're really not there yet. But so far, we're not seeing any, I say, concerning signals, but it is too early. So I think it's reasonable to be optimistic, but we're not on solid ground yet to talk about it being less virulent. And I think the WHO is appropriate in saying that, if suddenly you have 10 times as many cases, even if you drop the death count in half, you're still going to end up with more deaths. So, bigger denominator, we need to sort of be careful. We can't just let this spread like wildfire because the mortality, because the hospitalization is lower. And the other thing that we will not know for weeks, and I think most people listening are probably sensitive to this, is what about long COVID? What about the long-term effects? I think it's naive, and I think we all made this mistake, early on. Hopefully, a lot of us corrected that mistake, but it's not just about whether you live or die. It's not just about whether or not you end up in the hospital. It's how am I doing a month or two after that acute infection? Am I back to my role in my family? Am I back to my role at work? Am I back to my role at school? Or is my hair starting to fall out? Am I unable to go up a flight of stairs? Am I having trouble concentrating? So that we don't know about. And that's going to take a little bit of time before we know the answer to that. So Omicron, it is a fit virus. It is spreading. It is breaking through our monoclonals. We do not think it's going to break through the new oral antiviral. That I'm very excited about. I mean, this is like, now let's go to the good. We started off with the bad. The Paxlovid medication from Pfizer, the final data came out, and it came out yesterday. It looks better than the interim data. You get this medicine in the first 3 days, 89% reduction in progression. You get it out to day 5, you're still at 88% reduction. That's impressive. This is, you take a couple pills. It's actually a handful of pills, a couple pills, and then another one. So 3 pills twice a day, 5 days. But this is a small molecule. This is not a vaccine that requires really sophisticated manufacturing. This is something that can be produced in volume. So I am hoping it's just a matter of time. I'm hoping this year does not end without an EUA for Paxlovid, because that will change things. If we lose the monoclonals, we need something to fill that space. And I am really optimistic with regards to Paxlovid.
Do you think that that's a realistic timeline, that we could see it actually in people's hands by, and I assume that it is inexpensive to produce, is that correct?
So that's interesting. Inexpensive. They're going to charge us a lot. But no, it is not it's not expensive to produce a protease inhibitor. And that's what this is. How much will they charge? And it is interesting. See, what, $500 or $600 they'll charge us for a course. But if that saves us $44,000 per hospital admission, if that saves someone's life, which is really priceless, we can't forget that when we talk about dollars and cents. The trauma of being in hospital, and think about all the folks with long COVID. If you are shutting down that virus in the first couple of days, there's every reason to believe we're going to be protecting people from going on to develop long COVID.
I'm with you 1,000%, Dr. Griffin. I am not looking at the pennies on this. My question is only really on how the cost of production might impact the accessibility, because we saw such difficulties with accessibility to monoclonals. Part of that obviously being the physical fact that you had to go for an infusion, which if you have active COVID is not the easiest thing to arrange. Obviously pills are a lot easier, but we want to make sure that they are, distributed equitably and widely.
Yeah, no, you're right, Diana, because it's not the day that we get approval, there will not be, tons sitting on shelves. There's going to be a production lag. So the production will ramp up. And one of the nice things, I know we're not supposed to like big pharma, but I kind of want them to be my buddy in this one, is not only are they going to ramp up production at Pfizer, but my last I heard was 95 countries throughout the world. They're going to assist them. They're going to basically not enforce intellectual property. This is something that's going to be produced around the world, hopefully in quantity.
That would be incredible.
I think the problem, I think that the first quarter is just going to be hard because supply will be limited. I mean, Pfizer's already said they'll have 80,000 courses, or sorry, 200,000 courses, quote, this year. And I guess I'm a little pessimistic about seeing an EUA. They have to call an advisory committee on it, or the antimicrobial. I just don't see how they don't do it. Even if the data is that compelling, it just feels like one of those things that they have to do. And just knowing the government and looking at the holiday calendar, it feels hard for me to believe that we'll see. I hope you're right, but I don't know if we'll see EUA and kind of boom, boom, boom by the end of the year. And even if we do, I mean, think about the supply is going to be limited. So it's going to be like that kind of scramble, almost like at the beginning of vaccines. So it won't be as easy as like calling me and I just put it into the computer and you go fill it at CVS, for example. But think of how badly we need it right now. So I think that pressure is just going to create like a tension. And we were just discussing, not to doomsday this scenario, but I said, you know, we're going to have to probably in this like first several weeks of Paxlovid or any drug, because of limited supply, you'll have to make decisions about who gets it and who doesn't. And because that incredible data were in unvaccinated people, if I've got two people, an unvaccinated positive and a vaccinated positive, let's say they're both at equal risk, and I only have like one course I can offer, I'm going to do it in the unvaccinated person. And I think that's only going to inflame like what I think the country's like already inflamed emotions are about kind of how we're treating people, you know, who are we treating, how are we treating, why are we treating? But anyway, that's
I think those are excellent points. And I'm this will be, I guess, the time that I'm, you know, the sunshine. I'm usually not, you know. I have the opposite nickname around my house. You know, I think I am referred to as a bucket of sunshine, but with, you know, so that there's sarcasm.
Yeah, exactly.
So no, I'm going to honestly be the bucket of sunshine here. So, I mean, a couple of things that we have seen, and, you know, and this is, you know, sort of a shout out to get that third shot. I think we have learned over time that those mRNA vaccines are really 3-dose vaccines. Particularly because, as we know with this virus, there are variants. Like, we're not just trying to go after the ancestral Wuhan, we are trying to go after the variants. And it really does look, and I think good data on this, that if you get one shot, a second shot, that third shot properly spaced out, that you get high level, broadly neutralizing antibodies. It was actually good data out of the UK and some others, Israel as well, that there may even be not just a vaccine efficacy against infection, but there may be improved efficacy against severe disease, hospitalization, and death. We are hoping, and, you know, there is data that the vaccines are reducing, not eliminating, but reducing the risk of long COVID. But we're still seeing that. I was dealing with a young lady today in her 20s, double vaxxed, got COVID after that. Now her hair's falling out and she has thin hair to begin with. I mean, that's devastating, right? For a young woman. Well, I mean, anyway, but I can still empathize. But no, so I think this is right. What we just ran into recently here as of Monday in the local area, some of our facilities are rationing monoclonals only to certain higher risk populations. And I do understand the Pfizer EUA for Paxlovid, at least what they've requested, is initially just for unvaccinated, because that's what was studied. That's the highest risk group. So yeah, it is creating a lot of tensions where people feel like, I did everything I was supposed to. Right. I got my 2, I got my 3 doses. Here I am. I'm 70 years old. I'm an organ transplant person. Why am I not getting the Paxlovid? Why are you reserving that to people that didn't participate in the social contract? So it's challenging.
Yeah, these are difficult questions for sure, and it'll be interesting to see how it plays out, especially in light of our recent history where we have not exactly nailed it. I have a couple of quick comments to what you both said before we move on to the rest of the questions. One, Dr. Patel spoke about sort of what we know now versus what we knew then, and the research that is going on into long COVID. And so I want to just give everyone a quick update on what I know about that, which has to do with all of you. And Dr. Griffin also plays a part in this story. Last February, a Twitter conversation occurred where we were, Dr. Akiko Osaki from Yale was talking about the possibility of people feeling better after the vaccine people from their long COVID symptoms. And Dr. Griffin joined the conversation, said, "Hey, I'm actually seeing this in my patients." And then you'll all remember when I came barraging at you and got 2,000 of you to fill out a poll within 24 hours. And we were able to get that data to Dr. Iwasaki. We then started a joint Survivor Corps Yale vaccine study looking at autoantibody assays in long COVID patients before and after the vaccine. And that was a longitudinal study over the course of 12 weeks that we started recruiting by April. It was concluded over the summer and is now launching into its next stage of really attaching those symptom clusters to genotyping and getting to closer to therapeutics. So all those polls that you are filling out on Survivor Corps, all of the studies that you are asked to participate in, they are making a phenomenal difference. They are moving the needle, literally. So please keep at it. The second point that I wanted to make, and it's a bit of a question, but also sort of a comment on, I had actually asked Dr. Iwasaki recently about Delta and the fact that it had a higher viral load and congregated in the nose. Did she think that there was a higher likelihood of there being yet more neurological sequela? And she thought that that was a very real possibility. I'm curious as to your opinions on whether the same holds for Omicron, as if we know, and have you in your clinical practices seen yet more long COVID come out of Delta, or is it still too early to know?
Dr. Patel, you want to go first?
Yeah, I will completely plead ignorance in terms of whether the presence in the nares like could be correlated with that. But I will say that it's funny, we were trying, it's one of the reasons I'm a researcher by training, and it kind of drove me crazy. Diana knows this, and Suzanne and others at Survivor Corps. I imagine Dr. Griffin feels somewhat similar, hopefully, that we just didn't take breakthrough cases or thinking about the data around even any cases seriously. And I hated calling them breakthroughs because I said an infection is an infection, and we really should try to.
Infections is what they
right.
should.
We should just try to understand like what's going on. Part of that understanding what's going on, and there are a lot of reasons, and we can go into it of like why every sample does not get sequenced. There are a lot of staff-related financial reasons, logistic reasons, and then frankly, because labs, especially some of the commercial labs, don't hold onto the samples for long enough, et cetera. So, but I had this burning desire when we started to seeing Delta, trying to understand like basically could we kind of factor in like the viral load. You can even look at kind of cycle time and try to understand like how much viral load someone had as a way through their PCR. Could we try to understand if there's a correlation with some of the symptoms that they had? And certainly for the patients where I could get their PCR and actually have the conversation with the lab and try to get their threshold of their cycle times and whether they're low, which would indicate that there was a lot of virus, or high. If I could do that, then I would be able to kind of match and say, yeah, this kind of correlates with what we're seeing clinically. And that did happen, but the numbers were too small, and I don't know if it's generalizable. And so the only thing I'll say is that for people listening, watching, and kind of thinking like, okay, I know someone who had an infection, or I have an infection, like how can I kind of advocate to understand more about the implications of this infection and who I am and whether I'm at a higher likelihood of getting long COVID, X, Y, and Z. I do think that that's worth pushing. And actually my blunt advice is to try to get yourself to someone who's got a lot of experience with seeing long COVID patients. It's not going to happen. We've got in the GW long COVID clinic, we've got about a 6 to 8 month wait. They're not even taking names anymore. They've just got such a long wait. So there are a number of us that are trying to like cobble together. Dr. Griffin might have a more organized way, but we're trying to kind of cobble together clinicians who actually understand this a little bit better, but will also proactively collect data, because I do believe there's going to be a way at some point to say 37-year-old female with a history of rheumatoid arthritis on these medications. And in the beginning, it'll be pattern matching, but that's kind of how we generate hypotheses in clinical medicine, or trying to understand patterns of recognition. And we need more of that. I've been able to find that on survivor core, to be honest, or Twitter,
Yeah, I mean,
sadly.
also, I imagine the reverse of looking at these people, what medicines they were on and what their
Right,
stories were, and maybe why they were protected from
right,
it.
exactly.
I
So
always,
why exactly? You don't
right,
look
I
for
mean, I
just the
always give the
positive,
example
you
of
look
my
for the
husband.
absence.
Exactly. Like I always give the example
Right.
of my husband who has MS, who would have been, who, I was most nervous about getting it. I gave
Hmm.
it to him. He had the most mild case of anyone I know, but I suspect it's because he takes Copaxone every day. Um,
Yeah,
you know, who knows?
yeah,
Um, Okay, should we move on into reader to member questions because we're going to run out of time. I could go on forever with the two of you.
I know.
Elizabeth S. asks Dr. Griffin, with the holidays coming, how should those who have had COVID and are triple vaccinated celebrate? Is it safe to have fellow vaccinated people in the house? Over the summer, we were able to gather outside, but in the thick of winter, that's no longer an option for most of us.
Yeah, so this is tough, right? I think a couple weeks ago, everyone was planning this was going to be, like a normal Christmas. Last year, we missed a lot of the holidays. We missed Thanksgiving, and you were hearing from a lot of recognized public health people. This is all different. You're going to be able to have those holidays. And now suddenly we're seeing this exponential rise in case numbers. We're seeing our hospitals flooded. If mom slips on a wet floor and hurts herself, you don't want to take her to the hospital because it's fall. I mean, it's suddenly we're back in surge conditions, and not even just the COVID issues, but all the other things, of getting people together on the holidays. So how do you make things safe? And I think we've got to remember what we've learned over the last couple of years. So yes, number one, which was brought up, get that triple vaccination, get that booster. It looks like that's what these vaccinations require, is that third dose. And we're moving that down into the younger kids. It's taken a little longer, but we're following the science. The other is testing. Don't forget about testing. If it is a bunch of 30-year-olds and everyone's, triple vaxxed, and that's a different scenario than when, let's say, I get together and my dad is 90 years old, or my mother is in her 80s, and these are fictitious, right? So my mother's in her 80s, but has some medical conditions that compromise her, or maybe she's, you've got to be looking at that. And don't forget about those rapid tests. And I really think that's a huge thing. It is incredibly sensitive, these tests, for picking up someone who's potentially contagious. A lot of the bad rap that we heard early on about these tests don't work. Well, they don't work when someone knows they're positive and goes to the party anyway. But if you're positive and you don't go to the party, these tests are really good at preventing that. So think about these different layers: vaccination, making risk assessment of who's involved, thinking about the number of people that are there, looking at testing, and those tests are in short supply, so start planning ahead, opening those windows. I felt really bad. I had a patient who recently got COVID. Everyone got together for the holidays, and the unvaxxed family member was going around closing all the windows because they were chilly. Put on a sweater, get a vaccine, but don't close the windows. Keep those windows open. But so really start thinking about all the different things, and reach out to your medical providers. Reach out, and we're happy to answer questions.
Aparna A asks Dr. Patel, how safe is it to travel on a plane? I will say myself, I've been flying quite a bit recently, and each flight has been packed, literally every single seat taken. So air travel is back at it. It doesn't matter whether it's domestic or international. What are your best tips to travel safely?
Yeah, so it's been interesting. Airlines obviously have had an incredible motivation to make sure that they're back when we thought that that COVID was transmitted or had the ability to be transmitted through surface contact. You'll recall, like, everyone kind of had those robots, and they showed them on planes that did UV light, and now we know a lot more that it's airborne. And to Dr. Griffin's point about air circulation or popping a window, airplanes, so like an average room like I'm standing in, might kind of circulate air one or two times, maybe three at most, especially if you've got kind of, and then if I put some fans, maybe 3 to 5 times. Airline air circulation is anywhere from 12 to 25 times an hour, and that's a good thing. However, to your point, Diana, you're bringing up what kind of drives me crazy. I've only flown a couple of times. I'm about to fly tomorrow with my family on a 4-hour trip. And what kind of drives me crazy is when people then take their masks off, don't wear their masks properly, start eating and drinking. And then I just start getting very nervous because obviously that's close contact and certainly an airborne virus, as Dr. Griffin points out. Even Delta, I'll say it doesn't matter whether it's the Wuhan strain originally or a Omicron strain, which is very interesting now, kind of talking about transmissibility. It makes me incredibly nervous. Having said that, I am going to travel, and it is because I'm going to make sure that my whole family has a good fitting mask. I would say that your ability to calculate risk between domestic and international probably has less to do with kind of just the quality that it's domestic and international, and maybe more to do with kind of where you're going and coming from and to, and what the case, just what cases look like going in and out of those places. And I don't think that that's enough of a story, but if you're fully immunized, including a booster, good fitting mask, understanding that, you know, the airport itself and some of those close contact situations might be ones you might want to try to avoid, and not crushing at the front gate. And then also just being very mindful while you're on the plane, you can remain safe. And testing before you leave and testing when you arrive, to Dr. Griffin's point, can't test out of COVID, but it definitely gives you just those extra layers of security. Oh, what I was trying to say with domestic and international, it has more to do coming and going, length of flight. Also, we've seen a couple of cases. It's been very limited. The good news is we're not burgeoning with literature of all these people. Airlines have not become like the Carnival cruise ship. That flight, I have to ask Dr. Griffin, did we ever find out what happened on that Netherlands flight? Was it like a sports team that all was positive and they just happened to all be on that same flight, or did something happen on that flight? Because that made me worry. But in general, we're not seeing
There was
cases
no
in the
masking
literature.
on that flight, from what I understood.
But is that
That
why?
masking was not enforced.
Okay. So there you go. That's the explanation. But in general, we're not
I will
burgeoning
let
with
you know
literature
that
on
having
that.
done a 4-hour flight, I think it was yesterday or the day before, a 5-hour flight, there was no food served. Dr. Patel, you'll be pleased to know. There was no option to buy food. And they kept on repeating, if you are to take a drink, that does not mean that you take your mask off for the amount of time that it takes to
Yeah.
drink the entire drink. It's to take your mask off for as long as it takes to sip. So
Yeah.
that made me feel a bit better. In terms of the masking, what kind of masks are you going to be wearing? And I know you have little kids, and that has been a
Mhm.
big concern of how to find good fitting masks for air travel for kids. What will you be using?
Yeah. So I'll be using, I have an N95 for clinic, but I use every day a KN94. So that's what I'll be using for myself. And I actually did get child size. So my kids do wear those, and I'm lucky enough where they tolerate wearing it because it's not super easy. But that's basically what we're doing. I'm not wearing eyewear. I'm very transparent. I do wear a face shield. I have kind of a whole, I'm sure like Dr. Griffin, whole PPE get up I have to do in clinic, but I'm not recreating that, just the mask.
Okay.
I was on a flight recently, and you know the nice thing now is that supplies have gotten better, so you can buy U.S. made, U.S. quality N95s. And I was wearing one of those, and I was quite happy because you know what Dr. Patel was pointing out is the air exchange is really good. It's the people right around you. And the person right next to me, he was apparently nursing his burrito for the entire flight, which meant he could keep his mask off. And I kept sort of looking over, wondering, you know, when he might finish that burrito. But apparently it takes a couple hours to eat a burrito. And
you're a better person than me. I would have been like, are you going to finish that? Because if not, I will.
So yeah, so I mean that's what I've done, and actually we are going to fly right after I think it's like Sunday after the December holiday. We're gonna be on a flight. It's a 6-hour flight, and we'll eat and drink before we enter that high capacity location. We'll wear N95s on the plane, and when we get off the plane, we'll be very thirsty and hungry, and we will eat and drink afterwards. It's really the people right around you, but you can fly safely. And as Dr. Patel pointed out, we are not seeing a lot of super spreader events. They're isolated stories, and then we hear about them. So you can travel safely.
Good. So Gina E asks Dr. Griffin, Should those with high antibody levels and or extensive long COVID symptoms receive the booster shot? Which I really look at as two different questions. And my follow-up question is, what does high antibody levels mean?
Yeah.
Because we don't really have a threshold, do we, that we know gives you effective protection against anything. So maybe that was a trick question. I'm not sure.
No, I think it's a good
No,
question.
no, it's a great question, but
You know, it's
one I would like to hear the answer to as well.
Yeah, so I always make notes before I do This Week in Virology. It probably sounds like I'm just natural off the cuff, but I spend hours preparing what I'm going to say. And what's nice is the CDC is now keeping a page where they talk about SARS. They call it the science brief, and it's SARS-CoV-2 infection-induced and vaccine-induced immunity, and they basically make a couple of the comments that you were sort of hinting at. So there are a lot of studies that show that at a population level, people that have higher antibody levels are, as a population, less likely to end up infected, less likely to end up in hospital, less likely to die. People who have undetectable or low antibody levels are more likely at all levels. But the issue is we don't really have an antibody titer at which we can sort of do a cutoff and say, oh, you're above this, you're good to go. You can go to that big unmasked gathering. You can eat that burrito on the flight. You're not a risk to someone else. You're not going to get infected. You're not going to transmit. So at this point, unfortunately, we don't have, but I don't think it's unattainable. We do not have a reliable blood test that we can use, but we desperately would like to have this, because think about that description I talked about, a woman in her 70s or 80s who has, an immune compromising condition, maybe extra weight. You would love to be able to look at that person and say, ooh, even though we gave you 3 shots, you're not there. And what we do know over time is that total antibody that you look at about a month post vaccination, and this is probably true about a month post-infection, that high level, a lot of that is these really potent neutralizing antibodies. That's what we're excited about. But when we get 3 or 4 months out, even if that total antibody level is high, unless you have a specific assay looking at the neutralizing antibodies, you're not sure how much of that is the good stuff. So, I think the one thing, to go directly to your question on a practical level, is that I would not look at someone's antibody levels and then not let them have the benefit of finishing their vaccine series, which is what we're now realizing, getting that 3rd shot. But no, I think that there's a gap here, because we keep hearing all the time about these antibody studies, and then people go and say, but I got my antibodies checked. And I say, oh, great. Did you use that FDA approved validated correlation study? So we know what to do. And, that's just sort of a joke. We would like that.
And we're going to get to a point. I just have to put a shout out for memory cell immunity. So there's what the antibodies measure, and we put a lot of importance, as we should, because that gives us a lot of signals. But we are all hoping, I feel confident Dr. Griffin agrees, we're all hoping that, especially like this booster dose, that it kind of creates enough of that kind of memory immunity which is measurable, but not something that I can just go to LabCorp and pop a code in and measure.
T cells or B cells?
Right, T cells. There's a whole kind of T cell. Right. Yes, T cell at a minimum, but then there's a lot of other ways to look at that immunity, and that is promising, and it is something that holds. And it's another reason why I don't kind of think of antibody titers as that helpful, because that memory immunity may play a key role in it. Might be why boosters are really helpful as well, for a longer period of time, even beyond, we won't need hopefully a shot every 6 months for that reason.
Right.
Yeah, I think I'm jumping back in, Diana, because, memory B cells. And there was a really nice paper that I'm going to be talking about where they looked at that. So what about those people who have low antibody levels? Are they really as vulnerable as we think? Do they have to stay out of society, right? That's right. What people are thinking. And they did. There's a way to use these tetrameres to look for those memory B cells. And it actually looks like a chunk of people, even as those numbers go down, they've got that memory B pool ready to go.
So I will say personally, I did not have any T cells 9 months after having had a natural infection of COVID, confirmed infection. And I tracked my antibodies. I believe I had the first antibody test given in America at Columbia. I received David Ho's antibody test on March 28th. Wow. And tracked them monthly, and I continue to track them, both spike protein and nucleocapsid. I'm become the biggest antibody dork on the planet. But I did not have T cells, and there have been studies that show that those who get neurological long COVID, which is to me basically anything, that's not post ICU COVID, it's neurological long COVID, is correlated with an inability to generate a proper T cell response, which sort of adds to the difficulty of it all. Another question here about, so here's a question. Frontline workers got their vaccines early on. The first vaccine was given 1 year ago today. Those folks are obviously at 6 months, they were ready for their booster, their third shot, which I believe it should be called. Is there reason to believe now that they're 6 months past that they are in need of a fourth shot? And where's the guidance on that? Either of you.
So where's Anthony Fauci when you need him? Because he's a big proponent of fourth shots. Now, one of the tough things I want to say, we're learning as we go, right? And when you said, okay, it's a 2-shot, people are a little annoyed. Can it be one and done? Which we're realizing, okay, there is no one and done. Even J&J needs another shot now.
That was my next question about J&J, but
okay. and then a third shot. And oh my gosh, if you're going to make me do like a fourth shot, am I going to have to get a shot every fall, for instance? And I think that gets back to what Dr. Patel and I were talking a little bit about with the memory B cells, is we do think that this is sort of a basic immunology concept, and we are really actually testing all our concepts, is getting a shot every, we'll say October, having a high level of circulating antibodies, maybe even increasing the amount of antibodies at the mucosal surfaces. Will that decrease our risk of infection? Maybe. But then we've got to ask really the question now is, do we need to do that? If we can basically have people where it's a couple days of the sniffles, do we need to keep boosting people every year? And I don't think we know the answer yet. We are hoping, based upon the more recent study, that third dose may finish a primary series, and it may really reduce long-term people's risk of death, hospitalization, long COVID. But we don't know yet, but we'll learn. And if I have to get a fourth shot, if I have to get a shot every fall, I would much rather get a shot than get COVID.
Honestly, I'd take one every morning if I needed to. I had zero reaction to any of them. You can give it to me with my coffee and I'd be fine.
I love it.
If that meant that I could eat indoors in a restaurant again, please, I would take it in a hot.
Dr. Patel, how often are you willing to get a shot? Are you up for the daily?
So dental work is my most tragic nightmare. I'll do daily, shots in the gums if that's what it takes to. That's how badly but it also it's funny because I find that this is going to be like one of those things where people will use this if we need more shots in the future. People see like the booster and its very mere existence as like a failure, and I think probably I'm going to become a Dr. Griffin podcast listener because I think that it's just. We're getting, these viruses are kind of amazing when you think about just what they're willing to do to stay alive. And that's the name of the game. And so we're trying to kind of outcompete what is biology just pretty brilliant at like figuring out how to like survive. And so, of course, that's not static, right? So it's just hard. I think people have, wanted to say like, this is what it's going to be like. This is how it's going to be. And anytime I hear somebody, like when people put these arbitrary, like by September, things will be fine. Like when the White House had the summer of freedom in July, I'm like, what universe am I on? Or now like back to work in April. Why is April like some big month where we can like go back to work? I was like, what do you guys know that I do not know? Because I don't know anything about what's going to happen. I can only work in today. And that's how I think people have to take it. And it's not comforting. But I look back on a year, Diana, of vaccines, and I see now I'll be optimistic. Like, if you had told me we would have had vaccines that quickly, I wouldn't have believed you. Genotyping, regardless. So it's pretty incredible and pretty grateful that I've been able to make like virtual friends like all of you because I think that's the only reason we've survived, kind of candidly.
Seriously. I have two questions left and 2 minutes left. So we'll make them quick. We didn't really finish up the question of if you have extensive long COVID symptoms, if you had bad reactions to the first two vaccines with long COVID, if you're one of the subset of people for whom the symptoms got worse, should you get a booster?
Yeah, I'll just say we're recommending boosters. What we've done though, just given the mix and match, I'll be honest, I haven't had a couple of patients, and I've just consulted smarter people like Dr. Griffin who study this every day. We've actually switched them and done like a J&J booster for that individual. In fact, I just did that today. Someone who had had some problems after the mRNA series. By the way, there's a lot of contention about whether that was really the causal kind of factor, FYI.
Right.
That tends to come up. But yeah,
right. We don't know if someone could have gotten an asymptomatic infection during that
right.
time.
Just but all that aside,
right.
The mix and match data was so compelling. So we did J&J and felt pretty good about it. We'll see. Cross our fingers. But yeah, that was the decision we made.
Okay, and my last question of the day is going to go to Dr. Griffin because it matters to both of us personally. Because a fun fact is that before Dr. Griffin and I met through COVID, we met literally being on air together, and then only figured out that we lived in the same town up until last summer, and our kids had been in the same class for years.
Oh my God.
Yes.
That's crazy.
Oh wait, my wife knew Diana, but I worked too much.
I had met his wife, and I know him not well. And so I'm going to ask you, because this affects you just as much as it affects me. Do you have any idea when the 12 to 15-year-olds are going to be able to get their third shot? Because they are having post-vaccination infections left, right, and center right now because they're all 6 months past their vaccination. Why isn't anyone talking about it?
Yeah, no, we actually expect that to be soon. I got an email today that they're planning on having meetings. So I do not think it'll be a long period of time. And I think it's this evolution where, you want to have the safety data, but I think we're realizing the mRNA vaccines are a 3-dose primary series. And we're getting to the point where,
Doesn't Israel already have all of the necessary data to make these decisions?
Yeah.
And if they were able to make it, why don't we have enough data? That doesn't make any sense to me.
I agree with what you're saying. I'm on a data safety monitoring board, and there was this whole, with the holidays coming up, let's meet again. I was like, what are you talking about? We're in a pandemic. We've got 1,000 people dying a day. We've got thousands and thousands of infections. When we have the data, you don't work on a schedule. You work basically on pandemic clock.
Yeah, I sit on the NIH Recover Committee for their $1.15 billion, and could tell you stories that would make you cry on that about those same slow timelines. Okay, it is 6:01. Dr. Patel had a hard cutoff, and I know Dr. Griffin has to go, although I could ask him questions for hours. Thank you to the both of you so much. If you are not a member of Survivor Corps, please join us. Our website is www.survivorcorps.com, CORPS. Please sign up for our newsletter. Engage in every study and trial for which you qualify. So many of the answers to this novel disease lie in your body. And with our new model of citizen scientist collaboration, you are going to help bring answers to yourself, to so many others, and those with other chronic diseases that have been ignored for so long. So thank you for everything you do, sending health, happiness, mostly health and more happiness, for everyone to have a good holiday. Thank you.